So when should you suspect TB monoarthritis? Well, you should suspect it in patients who present with chronic arthritis of a single joint, usually large weight bearing, and this arthritis doesn't resolve with multiple treatments, such as steroids, antibiotics, NSAIDs, or if the symptoms are worsening. In addition, if you recall from the last slide, patients often report a history of trauma to the joint. Now, you also look are at-risk populations, such as patients with HIV, of course, anybody living in tuberculosis endemic areas, people who are older, people with diabetes, lupus, rheumatoid arthritis, and persons on immune suppressed therapy. You also want to look at the X-ray. Early imaging with CT, MRI, but at the very least X-ray, as well as synovial biopsy, are key to making the diagnosis. Radiographic features of tuberculosis are usually noted 2 to 5 months after the disease has started, and the classic triad of radiologic characteristics of TB arthritis is 1. Juxtaarticular osteoporosis, 2. Peripheral osseous erosion, and 3. Gradual narrowing of the intra-articular space. We also reviewed these earlier in the lecture, and you can review that again if need be. So you want to look for bony destruction that is specifically peripheral and periarticular, meaning it's around the joint, but it's on the lateral edge, on the outside of the bone. You want to look for osteopenia, which is loss of calcium deposition and actually loss of bone. So there's increased bone lucency and joint space narrowing on X-ray. If these findings are present in the setting of chronic symptoms, be concerned for tuberculosis. If symptoms, however, are acute, osteomyelitis is more likely. In a case series from Congo-Brazzaville, septic TB arthritis accounted for about 30% of all arthritis presenting to the rheumatology center. MRI, although not widely available, has been shown to be more sensitive in diagnosing features of skeletal TB, including tuberculosis of the wrist. Though again, MRI is not freely available in resource-limited settings, patients on immunosuppression, usually from rheumatologic disease or cancer, should be given priority for this test if there is any access to it, with a low threshold for imaging. But again, given the wider prevalence of X-ray and CT, I recommend familiarizing yourself with typical findings of TB on this mode of imaging primarily. But in the case you do have MRI available at some point, the features of tubercular arthritis include synovitis, effusion of the joint, central and peripheral erosions, just like on X-ray. You can have active and chronic pannus formation, a cold abscess, or hypointense synovium.